we'll move to our last presenter. And Celine, apologies if I butcher your surname. Daignault from University of Sydney, speaking on what needs to change to ensure LGBTQ plus people are included in cancer clinical trials.
Thank you. It's pronounced Daignault, like Renault, the car brand. And can everyone see my slides? Yes, lovely.
Yes.
Okay. And also somewhere across my wires, because part of our research team that I'm presenting the project for today is from the University of Sydney, but I'm from the Cancer Institute, New South Wales. So I think I've probably filled out a form incorrectly somewhere along the way. So everyone, really great to be here. My name is Celine, and I am currently acting in the role of Clinical Trials Optimisation Manager in the Clinical Trials Program at the Cancer Institute New South Wales. I use she, her pronouns, and my presentation today is focused on a recent project we conducted in partnership with UNSW and ACON, aimed at understanding LGBTQ participation in cancer clinical trials. If you have any questions or comments, please put them into the chat, or you can save them to the end of this presentation as well. I acknowledge the traditional custodians of the various lands on which we work today and the Aboriginal and Torres Strait Islander people participating in this conference as well. And I'd also like to acknowledge the voices of people with lived experience with cancer who contributed greatly to this project, and we're very grateful for their contributions. So beginning in May 2024, the Clinical Trials Program partnered with ACON and UNSW to conduct research to understand the representation of LGBTQ community in cancer clinical trials in New South Wales. This project started with a scoping review, followed by interviews conducted with clinical trial staff, all focused on New South Wales. So this, the focus of this work was heavily involved in the data collection practices within cancer clinical trials and sought to understand the barriers and facilitators of LGBTQ data collection. As I mentioned, I'm presenting as a representation or a representative of the project team at large. This was a very collaborative effort. So in this presentation, I'll provide an overview of the historical context for community inclusion in trials, the role that HRECs can play, and then also discuss the key findings from the scoping review and interview process. I think as a sector, we have a real opportunity to improve data collection practices for LGBTQ community. You can see there on the slide that a review of 764 clinical oncology trials in the clinicaltrials.gov website found that none of them reported LGBTQ status. And this means that we can't be sure whether any community members were actually included, or then stratify the collected data based on LGBTQ identity in the data analysis process at the end of the study. And then that all culminates into a lack of clarity on how the studied intervention will affect LGBTQ population. So I wanted to just take a really quick segue here and just acknowledge that it really would not have been all that long ago that the industry would have been discussing the relevance and importance of including women in clinical trials, 50% of our population. So it was actually only 2 years before I was born that it became legally required to include women in clinical trials in America. So women not being included in research has meant that we are being prescribed drugs and other interventions that may have only ever been tested on men or male animal models in preclinical studies as well. And we can really see how that sort of presents and manifests now. For example, science and society has historically considered heart disease as a men's health issue. However, women are actually just as likely to die from heart disease as men are. And there is really a lot of nuance to the way that women's heart disease presents compared to men. For example, the effects of pregnancy, how estrogen can act as a protectant for the heart, and then also the way that the symptoms of heart disease often start in women. And we would not understand these nuances if we didn't have correct and ethical consideration of the data that we're collecting. There are many other examples. So I just wrote there about hip replacements, and I used to work in sleep science, so I wrote obstructive sleep apnea. And I think that really demonstrates that trials desperately need to represent the populations that they will serve, and including LGBTQ populations is really important because they're a vital part of Australia's population as well. Yeah, so I just hope that helps kind of paint the picture a little bit more. This diagram, I think, just serves to show the effects and the like downstream effects of not collecting specific data points, and the erasure from the healthcare system it perpetuates for LGBTQ community. So this, I guess, perhaps inadvertent discrimination is underpinned by the common practice of data on LGBTQ population not being routinely collected or reported. And then again, we can't be sure if the intervention being studied is suitable and effective for the general population. This exacerbates marginalization, health disparities, and then also can lead to inefficient allocation of resources and public policies that exclude community. I wanted to highlight a few facts from the Out with Cancer report, which investigated trends for LGBTQI plus cancer care in Australia, and I think shows some interesting insights that are also applicable to trials. So within the Out with Cancer report, it was found that many clinicians involved in cancer care believed that cancer is the same for everyone and that they treat everybody the same. And in that, they really do believe, I think, that they are doing the right thing in not tailoring their care to LGBTQ population. However, what the Out with Cancer report found is that it not being standard practice and the clinician not having any consideration for any special consideration that might be required left patients fearing discrimination and left them feeling like they had to carry the burden of whether they should be disclosing their status and be asking any specific questions about their care in relation to their sexual or gender identity. And patients often noted this as the most stressful part of their cancer care, which I think is very poignant. And the Out with Cancer report also found that LGBTQ population experienced distress in their cancer care 3 to 6 times higher than the general population. Okay, so now that hopefully I've set the scene for everyone, I'd now like to just talk about our project. So the first aim of our project was to understand the data collection practices in cancer clinical trials in New South Wales. So really, what is known about the collection of gender and sexuality data in cancer trials? What are the current practices and what are the perceptions amongst healthcare professionals? So this was actually really difficult, and within the scoping review, there was not any identified literature from New South Wales or Australia. So there are 6 papers, and they were all from the US and the UK. And this is, I think, due to a lack of standardized reporting. So statewide clinical trial reporting systems and local health districts have electronic medical systems that currently do not capture data on gender and sexuality consistently. And you can see here that the findings of the review in terms of what impacts data collection is very varied. And I think this shows that a whole of system response is really required to better capture and perhaps increase, hopefully, LGBTQ participation in trials. Yes. From the scoping review, we then moved to interviews. So we used the data found in the review to help inform the interviews. And these ended up being conducted with 10 clinical trial professionals. So you can see here with varied roles within clinical trials. And within this interview process, respondents shared that they had an understanding that exclusionary language is often used in trial eligibility information. So for example, accepting only women for breast cancer trials, or using the term women instead of just saying in your inclusion that you accept anyone with a cervix. And that there's gendered language used across many trial-related documents. The people interviewed also noted that there was a lack of tailored information available to educate LGBTQ community around safe sex and contraceptive when prescribed cytotoxic agents. And then lastly, many respondents noted that having this information collected in terms of it being standard practice for LGBTQ community to be included in any data collection practices would just help it become a more natural and easy part of the conversation and remove some of the pressure that clinicians experience. I wanted to include an example here for language that might be used in a trial protocol. So you can see at the top, this trial is referring, or it is hoping to recruit men with prostate cancer. And I think, I don't want to say an easy change, but a change that could perhaps be looked into is to make it people who have prostate cancer. And so that could be applied in the protocol. It could be applied across all of the patient-facing documents. So I just wanted to hopefully provide an example that that resonates. So the second aim of the project, after the scoping review and interview process that had been done, was to develop recommendations for actions to support healthcare workers and researchers to improve inclusive practice. And to this point, there are two guidelines that I wanted to point out that are probably not light reading, but but good reading. So we have the ABS guidelines that provide information about the data sets that are recommended surrounding sex and gender. And then we also have the 2024 NHMRC statement, which refers to the ABS standard, but discusses the fact that any research funded under the Medical Research Future Fund or the NHMRC should be collecting data about sex, gender, and variation of sexual characteristics. So one recommendation from this project is that rather than the NHMRC statement applying to only research funded that way, it could actually apply to all research in Australia. And I understand to you listening right now, that might seem like a very lofty recommendation. However, our aim in presenting to you today is just to create an awareness and an understanding of why equity in this space is so important and how you can work within your HREC to influence outcomes for LGBTQ community. So I think that looks like, as previously mentioned in the slide, where possible, using inclusive language across all trial documents so that you're not excluding people just from the get-go. And then I think another area to look at is, where possible, could you encourage co-design with LGBTQ community so that they are, across the trial process, included and can be involved within the work. Here are my references. And thank you. Please reach out with any questions or comments. That's my email address, and I really look forward to seeing more fabulous work in this space. Thank you.
Celine, thank you very much for that presentation, and I particularly liked and made a comment in the chat about the practical recommendations. I think it's really important that we can take away things that we can actually do as researchers, but also as people on HRECs, advise our research community in terms of how they can improve their practices. So thank you so much for that. We'll wrap this session up.